Hello everybody and welcome to Community Conversations here at Atlantic Health System. My name is Luke Margolis. I'm the Corporate Communications Director for Atlantic Health, and today I am joined by Dr. Jason Lowenstein. He is the Medical Director of Atlantic Health System's Scoliosis and Spinal Deformity Center. Doctor, good to see you.
Luke, thanks so much for having me.
Sure. So this is not the first time you and I have chatted, but we're doing it in a new format today. So welcome back, sort of, I guess, right?
Thank you very much for having me.
All right, folks. So for those who have not seen Community Conversations before, I'll give you a little explanation as to how this is going to work. But before we do that, those of you who have seen this before have probably recognized something rather quickly. That Dr. Lowenstein, my guest for this show, and I are not wearing masks. This will be the first Community Conversation we have taped without masks since this programming started back in April of last year. So why are we doing that, you may ask? Well, both Dr. Lowenstein and I have been fully vaccinated, and we are not currently doing this programming in one of our medical centers. For those of you who are familiar with our visitation rules and with the governor's rules around masking here in New Jersey, you will know that masks are still required in healthcare facilities. So if you are going to be visiting a patient, or if you're going to be doing any other work in and around one of our medical centers, you will have to expect to continue to wear a mask. But for this program, we will not be doing so. So that's a little explanation as to how this is working. Now, again, for Community Conversations, this will be sort of a three-person conversation. Dr. Lowenstein and I will chat for about 15 minutes to a half an hour. But if you hear something that you find interesting and want to ask a question about, please feel free to participate by entering that question there in the chat box on the screen. We have also solicited some questions ahead of time. We will try to get to as many as we can in the time allotted. But as you can imagine, I've already chewed up about 2 minutes of that time. So we're going to jump right into it. Dr. Lowenstein, again, much appreciated. We build this, this conversation as living with scoliosis. And so those who may have it and been diagnosed with it may have an understanding about what exactly scoliosis or spinal deformity is. But for those folks who are tuning in suspicious that they might or maybe are worried that perhaps maybe they may be prone to this condition for whatever reason, what exactly is scoliosis and spinal deformity?
Yeah, so when you look at your spine, from the front, your spine's supposed to look straight. When you look at your spine from the side, there's supposed to be two gentle curves. Your thoracic kyphosis, which is balanced by your lumbar lordosis, kind of makes an S from the side, which is a gentle S. And that's what a normal balanced spine is supposed to look like. If you have deviation from that normal, so when you look at your spine from the front and it's curving or you're off to one side or the other, you might have scoliosis or some underlying spinal deformity that's making you do that. If you look at your spine from the side and there's an exaggeration of that normal S, so there's a big hump or a real significant prominence of your back, that could mean that you have kyphosis or another type of spinal deformity. If when you look at your spine, either from the front or the side, and you're way off to either one side or way off forward or backwards, that's abnormal, and that could be a sign of spinal deformity.
So those are powerful visual cues that regular folks can use to maybe begin to help identify. But from a physician's perspective, how do you diagnose this kind of thing? Is it usually a patient is suspicious that maybe there's something going on or there's some pain, and then they come and seek your counsel? How do we diagnose this?
Well, so there's spinal deformity that's diagnosed when you're a kid versus spinal deformity that's diagnosed when you're an adult. So when you're a kid, typically you're getting screened by your school nurse, by your pediatrician, your parents are looking at you, and if you see abnormality, one shoulder higher than the other, the ribs are more prominent on one side or the other, if you see folds on their back that looks asymmetric, that gives you a sense that there may be something going on, and typically those patients get referred to a physician or to be evaluated to rule out a spinal deformity. In adults, it's oftentimes that you feel imbalanced. You can start noticing that there's a change. It may be very subtle where you lean up against a chair and you feel like there's an abnormality. It doesn't feel like it used to be. Sometimes that happens in conjunction with symptoms. Sometimes adults start having pain. It can be back pain. It can be pain that travels into their buttocks or down their legs or numbness. These are all things that can happen that can trigger this concept that you might have an underlying spinal deformity.
So something you mentioned in there I think is worth reinforcing. This is something that can happen to both adults and young people?
Absolutely.
Is it predominantly young people, or can it be a mix of both?
No, I mean, so the most common type of scoliosis that's identified in kids is something called idiopathic scoliosis, which is a fancy way of saying There's no underlying diagnosis that creates the scoliosis. It's happening for some unknown reason. You start getting this curvature. They tend to follow very predictable patterns. And these curves sometimes are small curves that don't go anywhere. Sometimes they're curves that progress into adulthood. And those are ones that we worry about. We want to try to diagnose early and try to institute treatment early on to prevent it from progressing. Adults can develop scoliosis as well. They can develop degenerative scoliosis. So as you get older, the discs and the normal structures in your spine can start wearing out asymmetrically, and you start getting these curves. So that can happen in adults. Also, adults can get idiopathic scoliosis that develops as well, which is where there's no underlying diagnosis. It just happens, and if it does, we have to identify it hopefully early and offer treatment to try to prevent it from getting worse.
I think that's a great opportunity to switch into a conversation about treatment. I would imagine that those who, and certainly some of the cases must be fairly severe and disheartening for people to go through something like this. But treatment options are out there, right? I mean, this is something we can treat.
Absolutely, yeah, and we can treat patients of any age, but we do change the way we treat differently for kids versus adults, particularly the immature growing spine versus the adult spine, which is done growing. So in children, if you identify a curve, which is really a small curve, you tend to observe it to make sure that it's not changing. But if you find a curve which measures in that 20 to 40 degrees and they still have growth ahead of them, we tend to offer a brace as an option. And bracing has been shown to be incredibly effective at preventing the progression of scoliosis. So bracing in and of itself can sometimes be the main treatment, and it can be incredibly successful. There are a lot of different studies out there, but braces can be up to 90% effective in preventing the progression of scoliosis in the immature growing spine. So that can be a huge option to try to treat and an opportunity to stop them from having more issues as adults.
And by brace, we mean literally something that sits externally around the body.
There's a bunch of different types of braces, but they all sort of focus on, they tend to be a thin plastic brace which offers kind of a three-point bending. You're trying to push the spine straight, not to necessarily reverse the scoliosis, but to prevent it from getting worse. So it's a rigid brace. It's dose dependent, so the more you wear the brace, the more effective it can be. We tend to recommend that for most patients that they wear it 18 to 20 hours a day at least to try to give the maximal benefit from it. But that's an option for children.
Okay. Outside of bracing, what other options do we have?
So there are different types of exercises that kids can do to try to strengthen their spine and try to prevent it from growing, from the curve from getting worse. And in cases, once they get past about 45 degrees and it's a relatively big curve, we start thinking about surgical options to try to arrest the growth, but also to prevent it and correct it. There's different types of surgical treatment options for kids. One treatment option that is relatively new, that's getting more data and support for, is something called a tether. A tether is a minimally invasive surgery where you actually, with a camera going through the chest, and you actually put your screws into the front of the spine. But instead of putting a rod to connect the screws, you put a tether, which is a flexible cord. So you're trying to correct the scoliosis, but it's a non-fusion, actually mobile type of surgical correction, so that so patients hopefully retain their motion and they can still go back to all their normal activities afterwards.
In terms of how we treat adults, are there how are there similarities and where are there differences? Is bracing used for adults?
Bracing's not used as much for adults to try to correct the scoliosis or prevent it from getting worse, because in adults your spine is done growing, so you can't modulate the spine the same way. Now, patients that have adult scoliosis and have really bad back pain occasionally will offer braces for short-term use just to try to help them alleviate their back pain symptoms, but we don't use it to try to correct the scoliosis the way we do in kids, or try to prevent the curve from getting worse the way we do in kids.
I want to talk a little bit about the sort of the where treatment has been and where we are now. The creation of the Scoliosis and Spinal Deformity Center. And you and I have talked about this in a couple of other pieces we've done. In fact, for those who want to see a very real example of how the center is able to help folks out, we worked on Gianna's story together, which was a piece that's visible on our website. If you go to atlantichealth.org, you can see her story there, and I think that paints a pretty clear picture about how transformative this care can be for young patients.
It is. It's amazing. You know, when you're a child and you're living with this deformity, whether it creates a cosmetic problem or pain or inability to do the normal activities that you see your friends doing, by fixing this and allowing them to go back to their normal everyday routine, it's very wonderful to see that happen.
Those recoveries, are they, is it, I mean, it's very difficult to say if there's any norm because I'm sure everybody's circumstance is different, but the end result of a successful treatment, how restorative is it for a person's mobility, ability to enthusiastically enjoy life?
Yeah, the vast majority of scoliosis patients that ultimately progress to the point that they need to have surgery to fix it, they go back to normal activity, normal lives. It's an incredibly transformative procedure and experience for them, and they just go back to being normal kids and normal adults.
I love that. Nothing better than sometimes normal life in this pandemic world of ours.
It's a wonderful thing.
It's a wonderful thing, exactly.
It's a wonderful thing.
So we have a couple questions from the audience that I'd like to get to. The first is from Ray, and before we dive into our questions, I do want to just, as we always say, everybody's circumstance is a little bit different here. We try not to diagnose or respond in too much detail to anybody's circumstance through Facebook because, frankly, Dr. Lowenstein hasn't seen you yet, right? So we would always encourage use with all of our programming, go to our website, use the Find a Doc search tool if you're in need of a physician. Talk to your primary care physician if you have one. Those relationships are super important in helping get to the bottom of what's going on with you. And then, of course, reach out to the Scoliosis and Spinal Deformity Center if you think some of what you hear may be relevant. But I want to pivot to some of these questions. Ray says he's been diagnosed with DISH. And just for the audience, what's DISH before we get to the rest of the question?
It's diffuse idiopathic skeletal hyperostosis.
Excellent.
So it basically means that your spine is getting stiff and it loses its motion. So it can be symptomatic for a number of different reasons. If your spine gets really stiff, you lose range of motion. Sometimes it can happen as well that as it gets stiffer, it creates spinal stenosis, narrowing of the space available for the spinal cord and nerve roots. That can cause pain. It can cause paresthesias or weakness in your legs. But the other thing with DISH is DISH can create a spinal deformity. Once your spine starts getting stiff, you actually can lose some of those normal contours, and oftentimes you get kyphosis. You can't stand up straight. You're leaning forward with the inability to stand up straight. Sometimes you try to compensate by bending your hips and knees to try to get yourself straight, but you can only be in that position for so long without your legs fatiguing, and then you wind up falling forward again. So there are options for treatment for patients who have DISH.
Okay, good, his question essentially is, like you said, my spine is fused, and he's met with spinal specialists and neurologists. They all say there's nothing they can do in regards to surgery. So is there anything new in the fight against DISH? So the answer really is there may be, depending upon your situation.
Yeah, it really depends on what you have. But if you do have kyphosis or the inability to stand up straight because of DISH, then we have now been doing these very complicated osteotomies. They're called a pedicle subtraction osteotomy or a 3-column osteotomy, where you basically take a wedge of bone out of the spine and you close the wedge to try to create the curvature, the lordosis that you've lost because of the DISH.
Which would be there naturally were it not for the DISH.
And then they stand up straight. So it's complicated, but it's doable. So there are treatment options available.
Awesome. So Ray, hopefully you're watching and got the answer to your question. Elizabeth has a question about something that we touched on a little bit earlier, so maybe bears repeating in the event she's just tuning in. If you're diagnosed with scoliosis as an adult, what are some things that, in terms of daily practices, best things that folks can do in their day-to-day that will help them either mitigate the symptoms if they're not so bad, or really come to grips with what can be a debilitating thing?
So scoliosis obviously is a real spectrum of a diagnosis. There's very mild scoliosis and there are severe big curves. Mild scoliosis is extremely common, and what happens is that as we get older, our discs and our motion segments will sort of wear out, almost like you wear out the tires, on your car.
Sure.
And as it wears out, if it wears out asymmetrically, you start developing a curvature. If it's a very mild curve, there's really nothing to do. If you're asymptomatic and you happen to know that you have a small curve, there's nothing to do other than good normal cardiovascular health, exercise, all the things that you should be doing anyway, to be a healthy person. If your curve is progressing or changing, or you're developing symptoms, back pain, buttock pain, leg pain, numbness, weakness, those are warning signs that there's changing and that the curve, as it's changing, is also creating the spinal stenosis or pressure on the nerves, and those are patients that really should be followed. So at the very least, you should see your primary care doctor or see one of your spine specialists for an evaluation. And then typically we follow you. We just try to make sure that the curve isn't changing as you're getting older, because progression of scoliosis is a warning sign that typically we want to catch early and try to either treat or ultimately be able to arrest the progression of the curve before it gets out of control.
Are there things that folks should avoid doing? You know, weight training, things along those lines, or are those separate matters?
It's all okay. I mean, I would say that I would use common sense in the sense that, you know, I wouldn't try to squat 500 pounds.
Set any records or anything like that?
Yeah, I mean, just common sense of. But I think it's really, you know, you have to listen to your body, and if you're exercising and it doesn't create pain or symptoms, it's probably okay. If every time you do a certain activity it starts bothering you, then you may want to back off of that.
Can carrying too much weight just in general exacerbate this condition? So in terms of moderating your diet, things along those lines?
Not necessarily. Well, so the answer is probably, in the sense that the more weight your spine sees, the more stress it sees. So keeping your weight down is a good thing, but really scoliosis affects everyone, whether you're skinny or, you know, it doesn't take
it's not a lifestyle oriented
no
thing.
It just happens for whatever reason. It certainly can be exacerbated by weight, but no, it's really all comers can be affected.
Gail, and this is sort of along that same vein of exercise, Gail has noticed a popping sensation and sound along her spine as she planks, right? In terms of those core exercises that a lot of people do. How concerned should she be about that noise? It doesn't say anything about, you know, there being pain associated with it, Gail, so I appreciate the question, but it just sort of says popping sensation and sound. So how worried should she be?
Well, sound in and of itself usually is not worrisome, and the truth is that if you crack your knuckles, you make a sound, and your parents may yell at you to stop, but the reality is that we don't know that really causes anything. The spine's the same way. Your facet joints can pop and make sounds, which are the joints in the back of your spine. However, if you do have spinal instability, something called a spondylolisthesis, where one bone is shifted on the other, you might hear popping and clicking when you move, and if that popping and clicking is happening in conjunction with like back pain, or I feel a sharp stab, you know, in my back, my lower back, my leg, that's a little bit more concerning because there may be abnormal motion, and I would get checked out.
So we have gone over a lot of technical terms, or at least words that I'm hearing for the first time, so I'm going to presume that maybe some of our folks may look for some explainers as well. One of the words that somebody heard, I believe Susan heard in our conversation, just wants a little clarification on, is the word kyphosis. What is a kyphosis?
So kyphosis is when you look at your spine from the side. Kyphosis is an increased curvature of your back, usually your thoracic spine. So it's an exaggeration of that normal curve. So if you have a humpback or a dowager's back or something where it's a really prominent big curvature of back, that's kyphosis. It's an exaggeration of what a normal curve is. It can also happen in conjunction with something called sagittal imbalance, which is a fancy way of saying my head is way in front of my pelvis. Typically, when you stand up straight, your head's supposed to be directly above your pelvis when you look at yourself from the front and from the side. If your head is way forward, that's a sagittal imbalance, where from the side, sagittal, you're forward. So that can happen with kyphosis too, and that can create tremendous disability, pain, and it's very difficult to maintain that position. You get fatigue, your muscles have a very hard time being in that position, which is why sometimes people start using a walker or a cane to try to help support them. They put it in front of them to help balance them when they're leaning forward.
Got it. So a couple of, two questions which are sort of similar. So Luetta and Lois both have asked similar questions. One specifically for male patients, but the other is for just for either men or women. The treatment options available for patients in their 60s or adult patients. We've gone over that a little bit. So for those who may have missed that part of it, I know we're being a little repetitive, but let's just, for their benefit, let's just remind them again, for adults, what are just some general things that we might be able to provide for them at the Scoliosis and Spinal Deformity Center?
Well, I mean, so if you're an adult of any age and you have a spinal deformity with or without back pain and symptoms, yeah, absolutely, you should be evaluated and make sure that everything is that you have a reasonable treatment plan moving forward. If you have a very small curve, there usually isn't much to do, and for adults with small curves, really we don't worry about that very much unless it's something where it's progressing or worsening. Adults that have larger curves, though, we usually offer treatment options, and those options could be either physical therapy to try to strengthen their spine or core strengthening exercises, and they can do that through Pilates, yoga, lots of different ways to try to achieve that goal, to strengthen the muscles that support your spine. If you're having pain and you're having more difficulty with ambulation because of that, then there are other conservative treatment options available. There's pain management doctors that can offer either medical treatment and or sometimes injections, which can try to alleviate some of your pain and try to help allow you to either do more physical therapy and exercises or just try to knock out your pain in and of itself and try to help you get back to your normal activities. If those fail and you have progressive deformity with or without progressive pain, numbness, paresthesias, weakness, then we as surgeons come in and try to help fix the problem with you as well.
So I think really, and Lois, I appreciate the question, I think, and Lou as well, hopefully folks are, what they're gleaning from this, and certainly what I am, is that scoliosis and spinal deformity is not, the diagnosis itself is not the end of the line. There is much that can be done to resolve these,
Absolutely.
the quality of life for these folks.
Definitely.
All right, a few more questions that are coming through. So Nancy has a child who has mild scoliosis, 20% curvature.
Okay.
Would her child benefit more from doing something that I'm not familiar with, something called the, I believe is the Schroth method exercises, or wearing a brace? Does the Schroth method essentially, can it be a stand-in for a brace?
So Schroth is a type of physical therapy. It is a technique that was developed sort of at the turn of the century, and it was really developed to try to treat patients with polio. It's out of Germany, and it was this very specific type of strengthening exercise to try to strengthen the muscles around your spine and to try to help correct scoliosis. Schroth is, patients anecdotally, a lot of them really love Schroth. It is, it's not always available everywhere. Some physical therapists gain some Schroth techniques, but really true Schroth is a very time-intensive type of program. The insurance companies don't always approve it. Sometimes you have to pay cash to do it. There's some
patients would always want to check with their insurance company before doing that.
However, Schroth is relatively new, and we're still looking at data to try to help guide us in terms of Schroth. There isn't the same amount of evidence that we have for Schroth that we do for bracing. So bracing has been shown without a question with some really wonderful, relatively recent studies that shows that bracing is incredibly effective in trying to slow the progression and treat scoliosis. So the issue with bracing, however, is that it's time dependent. You have to be in the brace for a long period of time, 18, 20 hours a day. So some patients just don't want to do it for whatever reason. But bracing is incredibly effective, and if your child is willing to wear a brace, then I would highly recommend it because it really has been shown to be very effective in trying to successfully treat scoliosis. That doesn't mean you can't do both, and Schroth can be wonderful too. And I wouldn't do Schroth in lieu of doing bracing. And certainly, if you're seeing a spine specialist and they've recommended a brace, I would certainly take the recommendation and do that.
Excellent. And of course, to reiterate, if folks have physicians they're working with, great. We always encourage those folks to seek that level of consultation. If they do not, you're welcome to come to atlantichealth.org and use the Find a Doctor option there, and you can find a number of physicians here at Atlantic Health System, Dr. Lowenstein included, who can certainly help with your condition. We have another one from Michelle. It harkens back to tether, which was something we talked about earlier in the program. Michelle's daughter has a 29-degree curve.
Okay.
Now she's 11 years old.
Okay.
Better to wait until she's a little older to consider something like tether, or is now the time to consider something like tether before she grows a little older?
Well, so typically,
knowing that everybody's circumstances.
Sure. I mean, by the book, the indications for tether right now is a curve between 40 and 65 degrees. Those are the typical curves that our tether becomes an option for. If it's a 29-degree curve, it's probably a little bit less than the average curve for tether. But 29 degrees is probably a great curve to be braced for. So, if you're not being braced, it would be an option to certainly consider doing that. And I think certainly if you're not being treated, you should come in to see one of the doctors in Atlantic Health. But certainly, if you have a doctor, I would discuss with them about it.
Perfect. We just have a few moments left, so I just want to recap for our audiences the members of our audience who may be joining us a little late. The Scoliosis and Spinal Deformity Center here at Atlantic Health System. Comprehensive center, obviously, but tell us a little bit about it. Tell us a little bit about the work you do and what folks can expect if they receive treatment.
Yeah, I mean, the point of the center really is to offer comprehensive care for patients of all ages, from birth to the end. And really, there's no age cutoff for treatment of spinal deformity. And it's a comprehensive approach. So whether it's bracing, whether it's therapy, whether it's tether, whether it's surgery, whether it's you have progressive deformity or you have pain, we want to try to provide an option for treatment for all children and adults that are living with scoliosis and spinal deformity and trying to find a better way to move forward.
Dr. Lowenstein, thanks so much for joining us today.
Great, thanks so much, Luke, appreciate it.
All right, folks, so there you have it. We covered a lot of ground today, so if you missed any part of today's discussion, the whole video will live on our Facebook page. It'll be on our YouTube channel, and you can find links to all of that too on our website, atlantichealth.org. All of our community conversations live there too. So if you missed some of this or want to learn about any number of other subjects, COVID related or otherwise, we have them all there on our website. We encourage you to check them out. So again, my name is Luke Margolis, and for Dr. Lowenstein, thanks so much for joining us, and we will see you next time.